these are my disclosures, but now I have two very important conflict of interest. One is that Javier is one of my best friends, and if he say me, come here, I leave all. And the other conflict is that I am a rhythm believer. And I try with this talk to convince you and go on like a rhythm believer and maybe in the future rhythm lovers too. What is rhythm? What are about when we talk about rhythm? Rhythm is a minimal invasive technique that apply water vapor inside the prostate, and for this we use a rigid instrument that use a 30-degree lens for that. In the top of the instrument, we have a needle that put inside the adenoma. Inside, we applied this thermal therapy that gets increased very quickly the temperature in around 9 seconds each cycle of treatment. With this effect, we can show in the MRI and below in the cystoscope how the adenoma decrease in volume and the obstruction is released around 3 or 6 months around. And when is the moment in which start all this history? In 2015, this group published a little study in which we can show how the rhythm is not inferior to TURP in terms of efficacy, but it's so much better in terms of safety because the complications are minor and the alteration in the sexual sphere are very, very few, not like TURP that all the people know. Several years after, the McVary group published this long-term study that includes around 200 patients. It's a randomized study in where we can prove the long-term results in a very select group of patients that you can see in the diapositive. This efficacy is maintained along the 5 years, and more or less you can get the best results around the 3rd month until the 5 years almost. And there is no difference if your patient have or no median low. That is a very important issue that difference this technique versus other techniques that we have presented previously, like ITIN or urolith, for example. And in this study, we don't show a difference between moderate and severe LUTS, for example. The complications were minor, like Clavian Dindo 1 or 2, and mainly was dysuria or hematuria, but normally these complications are resolved around the 1st or 3rd months after the treatment. The rate of retreatment it's around 4 or 10% at 5 years in relation with retreatment with oral medication or retreatment with surgical tube. We don't show any difference in the de novo erectile dysfunction or alteration in ejaculatory function. That is a question very important that we have talked before the lunch. Maybe we can talk about that in the discussion. But there are the principal studies. What about in the real world data studies? Well, there are several studies published about that. You can see that there are no so selected cohorts like in the previous study because, for example, you can see the range of BPH sites runs from 20 to 120 grams, for example. And I want to remark that in the questionnaires that these studies make to the patients, more of them show to be satisfied or very satisfied after the treatment. For example, patients that have a urinary catheter before the procedure could avoid the urinary catheter after the treatment. Then we talk about this kind of patients better. More recent studies, in this case a meta-analysis that include around 1,000 patients, confirm the safety and the efficacy of this technique in this group of patients almost in a follow-up of 1 year. And it's normal that you think, well, Mario, you want to convince me to be a Rhythm believer, but only 1 year? It's true. Before we have talked about 5 years in one very select study, but in this Swiss study published the last year, we have 200 patients that with follow-up around 5 years that replicate the same results that we have seen in the McVary study. For that, I believe I am convinced that this technique could be a good option not only in short times, too in a long time period for our patients. And what about our results? In a work that made with several centers, many of people that are in this room are included, we evaluate our first results, our first experience with Rhythm. It includes around 140 patients, and in this study we could see how in the centers that began with the technique we replicate more or less the same results that in a pivotal study published. But our cohort was so very selected, because if you see the picture, you can see a wide range of BPH site, for example, or so much obstructed Qmax in the functional study. This what our data about the technique is in a very fast technique. We perform this technique in outpatient clinic in the same room that we make the lithotripsy, for example, not in the main room, in the main surgical room area. And the surgical time since we introduce the gadget and finish the procedure is around 6 minutes, no more than 20 minutes from the patient comes to the room and go go home. Normally, we need to stay urinary catheter for 4 days. In our center, we normally use the catheter 3 days, more or less, and with our complication mainly was hematuria, dysuria, and urinary retention too. In relation with urinary retention, we show that the site of the prostate, normally more than 80 milligrams, or have a bladder catheter before the procedure, increase the risk or to need urinary catheter after the procedure. These are the functional result at 12 months. And the last year published another multi-center study with the Fundación Puigvert, in which only include patients that present the same characteristics that McVary study include, but with a follow-up of 2 years, and compare the different protocols that in the centers included in the study use. These are the characteristics of the patients, and you can see normally how many injections we use, normally 4, 6. Now the tendency is low is better. No, to use more injections get better results, it seems. And only 30% patient we have to go to hospitalization. Normally at discharge, we use anti-inflammatories like ibuprofeno or alpha blocks like adjuvant treatment almost 1 month after the treatment. You can see in this table the difference around antibiotics prophylaxis or the number of days that each center use the urinary catheter after the procedure. But we can demonstrate that almost at 2 years of follow-up, we maintain these good results in terms of symptoms, on quality of life, or in terms of uroflujo, Qmax, for example. Well, when you introduce a new technique in your hospital, mainly in the public system, it's important to evaluate the cost effectiveness of this technique. It's true that these now techniques have a cost mainly because the machine. But if you don't need to stay in hospital, all the complications that suffer after the technique are minimal and don't go to the urgency, for example, the total cost are reduced dramatically. And if we review and make an analysis about that, it seems that in a period of 4 years, more or less, if we apply Rhythm in a 10% on all the patients that could be operated for BPH, we can save around 30 million of euros. That is no a joke, I think. Okay, there are no comparisons of Rhythm before versus oral treatment, but we can indeed compare it with the result of Mentops. In this picture, you can see how Rhythm is better in terms of improvement of symptoms, but slower progression at low time and no impact in sexual function. And there are a few works that compare Rhythm with other minimally invasive technique. It seems that compared with the Rhythm could be better for a long time in terms of improvement of LUTS, for example. But I don't know if you are convinced to use Rhythm by now, but it is what is the ideal candidate to start, because you have to show several studies, what big prostate, for example, or a patient with a urinary catheter. But in my opinion, you have to select well your first patient to be combined or to get a good learning curve. That is short, but it's important to start with a ideal candidate. I recommend you this talk the last year in the European Congress that summarizes all this issue about that. It's not a good option in high bladder neck or prostate less than 30 grams. They don't improve better or so much, and it's possible that people worse. It's true that there are evidence in prostate higher than 80 grams, but I think that it's not a good idea to start with this kind of patient. In our series, I told you before that was patient that suffer more acute urinary retention or need retreatment more than other people. And if you do that, you have to manage this in different way. That if you treat prostate like 40 or 50 grams, maybe you have to maintain the catheter for more days than in the other cases. It's a no good option, in my opinion, to treat patients that suffer irritative symptoms, because with Rethon, almost the first or third month, you suffer de novo irritative symptoms, and in these cases, you can worse the irritative symptoms that they have in baseline. And when you analyze what are the evaluation of the patient in function of the symptoms that they have, you can see that if you have several lots before, maybe you will need more probably reintroduce any type of medication, for example. This is our flow chart in which we include Rethon in several points of this. Normally in prostate between 30 and 70 grams, or in high and bigger prostate, in which a surgical procedure is no indicate for comorbidities, for example. And my ideal candidate, it's summarized, is mild or moderate symptoms, someone that have poor tolerance or don't want to suffer any of the alteration in relation with the medication. Maybe it could be the retrograde ejaculation. No so much obstructive symptoms, because they have more probably to need urinary catheter after treatment, and less than 80 grams to start. Always that they want a definitive treatment, because remember that oral treatment is a palliative treatment, not a definitive treatment like this. You are invited all the course that we do in my hospital. The sponsor is Boston, and it will be a pleasure to receive in Cantabria. Thank you so much.